On-the-scene video coverage of TCT 2012 is supported by Pradaxa.
And thank you for the opportunity to share our results from FAME-2. The cost-effectiveness of fractional flow reserve guided percutaneous coronary intervention in patients with stable coronary disease results from the FAME-2 trial on behalf of the FAME-2 trial investigators.
Excuse me 1 minute. Please mute your lines if you are calling in. If you don't mind, I'm going to cut it off, okay? Okay, sorry.
No problem.
Opera is very nice, but we need to move on. Go on.
I think you saw my conflicts of interest. I received research grant support from St. Jude Medical, and St. Jude Medical is the sponsor of this study. As a reminder or reintroduction to fractional flow reserve, because it plays an important role in this study, it is a method that we have in the cath lab for identifying whether or not a coronary narrowing is causing significant ischemia. The angiogram has been our traditional gold standard for diagnosing coronary disease, but what we've learned is that it can be misleading in some cases. A very severe lesion may not be causing significant ischemia, whereas a mild lesion may be. And by using a coronary pressure wire to measure the pressure of the blood flow beyond the narrowing and comparing it to the pressure in front of the narrowing during maximal flow, we can calculate an index fractional flow reserve, which that tells us or informs us whether or not this lesion is actually causing ischemia and likely to go on and cause symptoms in future events. In FAME-2, we evaluated patients with stable coronary disease with single, double, or triple vessel involvement for PCI with drug-eluting stents. The difference between FAME-2 and prior studies looking at PCI in stable patients, for example, COURAGE, is that FFR was first measured across all lesions. And if all lesions had an FFR greater than 0.80, meaning that they were unlikely to be the cause for symptoms and unlikely to go on and cause cardiac events because they were not hemodynamically significant, then the patients were not included in the randomized portion of the study and fell into a registry. However, if at least one stenosis in a major epicardial vessel had an FFR less than or equal to 0.80, indicating that there was significant ischemia present, then the patient was randomized in a 1-to-1 fashion to either FFR-guided PCI plus medical therapy versus medical therapy alone. And the primary endpoint was death, MI, and urgent revascularization at 2 years. Now, the study was stopped early after enrollment of 888 patients and a mean follow-up of about 7 months. Because the primary endpoint occurred in a significantly higher proportion of patients in the medical therapy arm, 12.7%, as compared to 4.3% in the FFR-guided PCI arm. There was no difference in death or myocardial infarction, and this was driven entirely by a highly significant difference in urgent revascularization. In addition, the freedom from angina at 1 month was significantly greater in the FFR-guided PCI arm. And so this raises the question of whether these benefits are worth the cost of FFR-guided PCI with drug-eluting stents in all stable patients up front. And so that was the goal of this analysis, was to look at the economic implications and the quality of life implications. Now, the quality of life at 1 month, a significantly greater percentage of patients in the FFR-guided arm had minimal or no angina. And the utility change, which is a reflection of their quality of life from baseline at the time of enrollment to 1 month, was significantly greater in the FFR-guided PCI arm compared to the medical therapy arm, where there was essentially no change in utility. When we look at costs, there was a significant cost difference at baseline of approximately $5,500 because of the higher cost of drug-eluting stents in the FFR-guided PCI arm. That narrowed down to $2,500 at 1 year. And it looks like, looking at the slope of the curves, that might continue to narrow with further time. And this was driven by increased revascularization rate in the medical therapy arm. It's important to note that a small percentage of patients made it out to 1 year, so our estimates have a wide confidence limit. We calculated the cost-effectiveness ratio in 2 ways. The first was the in-trial results, where we looked at that cost difference at 1 year and we divided it by the change in quality of life at 1 year, assuming that the benefit of PCI lasted only 1 year and no longer. We think this is a very conservative estimate, and we found that the cost-effectiveness ratio was $53,000 per quality-adjusted life year. We also looked at a 3-year projection, where again we took the 1-year difference in cost, assuming that it wouldn't narrow any further over time, and we looked at the quality of life change, assuming that it would last out to 3 years, and then at that point there would be no longer any difference between the two groups. And we found that the cost-effectiveness ratio with this more realistic estimate was $32,000 per quality-adjusted life year. To put these findings in context, one traditional standard, $50,000 per quality-adjusted life year based on hemodialysis. If a strategy falls below this, it can be considered cost-effective. The WHO has proposed another standard because many think that this may be outdated, this number. That's based on a country's GDP, and for the U.S. it would be $150,000 per quality. Any strategy that falls above this is likely not cost-effective. And strategies that fall between $50,000 and $150,000 are debatable, and some would consider cost-effective. So how do our results compare to prior studies? Encourage the cost-effectiveness rate. Encourage angio-guided PCI was compared to medical therapy, and the cost-effectiveness ratio was at least $168,000 per quality-adjusted life year. In FAME-1, we compared angio-guided PCI, like done Encourage, to FFR-guided PCI, and found that
No.
yeah, I have no control over that.
No control over that.
Yeah, at the time, I ran out of time. We compared angio-guided to FFR-guided and found that FFR-guided PCI actually dominated, meaning it cost less money and improved outcomes. And now in FAME-2, we compare FFR-guided PCI to medical therapy and found an attractive cost-effectiveness ratio of $32,000 per quality-adjusted life year. Thank you for your attention.
Thank you. So this paper and study is open for comments from the press. Any questions? So I have a question. Bill, you showed us an incremental reduction or improvement in the cost savings over time. Upfront cost reduction with 50% over time, but a cost a $54,000. So actually, in reality, not cost effective, or yes, cost effective. The bottom line.
Yeah, the bottom line is that we think that it is cost effective. We want to be conservative and not overstate things, and so that's why we gave that what we call the in-trial results, because we don't have longer-term follow-up available to us at this time. But we think it's realistic that the benefit of PCI lasts more than 1 year, and that's based on data from Courage, where freedom from angina lasted out to 3 years. So I think that with that scenario, the cost effectiveness is $32,000 per quality and attractive.
Okay, so an attractive cost effectiveness. Yes, please introduce yourself. Tell us where you're from.
Larry Hammond, Life Daily. Doctor, what do you think are the practical barriers to widespread adoption of this technology now that we've seen FAME-1 and FAME-2?
Well, I think that the adoption has increased already since FAME-1, and it's continuing to increase. I think as FFR guidance makes its way into the guidelines, that will continue to increase it. I think the practical barriers include familiarity with the technique, learning how to do it, and physicians are becoming more and more familiar, and I think those barriers are going to become lower and lower, and we will see a continued uptick in its use.
Dr. Faxon?
So, the trial's a little bit not sort of practical as far as practice goes. And if we followed guidelines, would say somebody with stable angina, 1, 2, maybe even vessel disease, maximize their medical therapy. If they continue to have unacceptable angina, then then do intervention at that stage. If we applied that same sort of guideline.
Captain, can you pull the mic just a little closer?
Is the mic on?
Yes.
Yeah, it's on.
Okay.
So if we followed guidelines, how would this apply? Can you extrapolate this to actually what most people have been practicing so far?
Well, yeah, I think you're right. Based on Courage, people have argued that upfront optimal medical therapy should be achieved before proceeding to PCI. What we feel that we showed in FAME-2 in the main trial was that if you can identify ischemia-producing lesions and isolate those benefit from PCI upfront as compared to optimal medical therapy by decreasing urgent revascularization and improving quality of life.
But the improvement was really just preventing a revascularization and not death or MI. So there were no hard endpoint differences between the trials.
Yeah, in the short time horizon of the study, there was no hard endpoint. We don't know if we had followed patients further whether that would have changed. Our landmark analysis suggests that it might, but I don't think it's fair to shortchange the improvement in quality of life and a reduction in having to come back urgently to the hospital for revascularization. And I think this component is key because now it adds the cost relationship to this and shows that, in fact, it's cost effective to do that strategy.
Well, it may be cost effective, but that's very much in the eyes of the interpreter. And the question I have, because we wrestled with it, I was a member of the Data Safety Monitoring Board for this trial, and we stopped the trial. And that's about the only question that's been addressed to me for the last 4 days is, why did we stop the trial? So, and the answer is because we did. And we thought in the interest of patient safety, we would stop the trial. I want to ask you, in terms of these urgent revascularizations, how confident are you about the proportion that really were urgent? Because, the issue is that the patient knows they have a lesion. This is not a blinded trial. You can't do a blinded trial. So they know they have a lesion there. So that patient then gets some chest pain, and suddenly it's an urgent revascularization. Have you been able to get your hands around that a bit better?
Yes, we have. First of all, I think we do have a control arm. There are the patients who had angiographic lesions and had symptoms that were not hemodynamically significant. These patients were told that they had a lesion, but it wasn't significant. They knew they had a lesion too, yet they didn't present with urgent revascularizations at the rate that the patients who had hemodynamically significant one. The second component is that of those 11% or so of urgent quote-unquote revascularizations, half of them were driven by either biomarker elevation or EKG changes. And if you just look at that half that were driven by so-called hard reasons for urgent revascularization, it was highly significantly greater than in the FFR-guided PCI arm, 0.5% versus about 5.2%, something like that. Don't quote me on those numbers, but the p-value was less than 0.001, 83% relative risk
So
reduction.
that's actually what drove us.
Yeah.
But important to note that even with those, there was no difference in the hard endpoints, and we would love to have seen this trial go on longer, because even for the quality of life and for the cost effectiveness, as you pointed out, how important it would be to go on. So, Dean, last words, because we've got to move on, and we always want to hear from you.
Thank you, Roxanne. I'll try to be quick. It appears to me, Bill, that the curves for the primary endpoint are divergent. The curves for cost are convergent, and so that the cost benefit should be incremental over time, very frankly. And so I would say you missed the opportunity to have longer term follow-up to show incremental cost effectiveness, and I would not discount the freedom from angina, particularly class 3-4 angina, that is a surrogate. The analogies to Courage, 43% had little or no angina to begin with, 32% crossed over from OMT to PCI. I don't think there's any real good analogy with Courage because, to my knowledge, very few of those patients, the minority, had any objective ischemia documented. So
an excellent point.
Very positive trial.
Thank you, Dr. Kirax.
Thank you, Dr. Ferron.